Good morning. Thanks for being with us for this special show. It's a Good Day PA. I'm Amy Kem. A Central Pennsylvania boy began his stay at Penn State Health Children's Hospital much earlier than expected. Here's Waylon's story.
So when we got pregnant with this one, it was different and it felt different. And I kept going to appointments saying I'm having issues like bleeding and things like that. And then we had our 20-week ultrasound at 18 weeks. And it was at that appointment that they noticed that my cervix was opening. And it wasn't like, oh, you're having this baby. It's kind of like, we need to watch this. But I was bleeding and a lot. So they're like, we can't tell what's happening. So we need to cut the cerclage. And when they cut it, I immediately went to 7 centimeters.
The nurses and the staff and the doctors that came in to talk to us prior to delivery, that there was a large risk with him being born so early.
It's a challenge because those types of babies are fragile. And we know that there's unique aspects to their physiology being born at such an early age that we have to be cognizant of and really, really pay attention to so many minor details. Growth is obviously the most important thing. And so there's many things that we do to optimize that, because when you're no longer inside of mom, there's many stresses put on the body that make it more difficult to do that. The NICU is a roller coaster. All of our families will tell you that. But in Waylon's case, his family just was so strong, so resilient, so engaged.
Waylon was born, he was 1 pound, 12 ounces, 13 inches. Originally when he was born, I tried to sit up to see him and couldn't. So they actually brought a picture down, but I don't think it really hit me what he exactly looked like until I was released to come up to the NICU, and I think it was shock. His skin was kind of translucent still. It was really incredible to see.
In the beginning, he was one of our more critical kids, and he required a lot of eyes on him, a lot of hands-on care.
Basically, the nurses and the staff did a great job of making us feel at home. They did a great job of caring for my son. They did a great job of caring for my older son, who would come into the room and want to play and want to just be a little kid.
Their lungs are not fully developed, and they won't be for some time. So for many weeks and sometimes months, they'll require extra support to their breathing. And that's critical, because without that extra support, it's going to be very hard for them to also grow. So that was certainly the case with Waylon. He did need help with breathing for a number of weeks. Certainly we gave him the most optimized nutrition possible. Mom was able to provide milk, and we obviously keep temperatures stable within a good range in devices like the one that you're seeing in the incubator. So there's a very careful balance to all of those things, the nutrition, the electrolytes, the breathing, everything kind of has to be considered carefully every day, multiple times a day, to ensure that our babies have the best outcomes.
So when we look at a level 4 NICU, which is the highest level NICU, they take care of the sickest children. They're relying upon some of the other NICUs in the area, the level 3 and level 2 NICUs, to help care for those children. And so the fact that we have an outstanding system where when a child is extremely ill, they need to come here and we can take great care of them. But then once they're stable, once they're getting better, many times we can actually talk about sending them back home closer to their house at a NICU. Because again, we have a great catchment area, we have a very large area that we receive children from. But an hour or 2 hours a day is a long time for many families to travel. So the fact that we have exceptional NICUs elsewhere allows us to maybe get them back closer to home at an earlier date, so it's less stressful on the family.
Several years ago, decades ago, people weren't really sure if babies born at 24 weeks could do as well as he has. And now we're seeing babies even younger. We have patients born here who are only 22 weeks at the time of delivery, and they are thriving, and they are meeting their milestones and growing and developing. So the chance to be a part of that is extremely rewarding.
I keep in contact with a lot of the children that I've operated on. I can remember many of those children, even 10 or 15 years ago, that we met on the first day of their life.
Penn State Health Children's Hospital is so special. We take care of our babies when they're so tiny, and we see those glimpses of how resilient they are, even then. But to see him now thriving and so happy, and to see how he's just flourishing developmentally, it's absolutely incredible.
We have kids that have been here for months and months and months, and their family is seeing you sometimes every shift 3 times a week for 12 hours straight, and you really end up being a part of their family, and you kind of feel like they're part of yours.
I remember a nurse taking my older son and parading him around the hall, almost like it was her own. And that was just a huge help. There's just so many times where they just cared for all of us well.
Thanks for loving my boy and checking on him, and even when you weren't his nurse that day, just saying, you know, I just wanted to come in and check on Waylon today. So it's those small things that really made you feel special and seen and not just another number.
Waylon is doing well and reminds us why families from across the region have been coming to Penn State Health Children's Hospital for more than 30 years. They are looking for expert care for children. And joining us now is Dr. Rebecca Burke, who you saw in that piece. She's a neonatologist at Penn State Health Children's Hospital. We heard a little bit about this, but what makes a level 4 NICU different from other neonatal care units? Why is that so important for critically ill babies?
Thank you for that question. I think in my mind, the most important thing for families to understand is that if your baby is admitted to a level 4 NICU, you will not be transferred anywhere else, because every possible subspecialty or service that your baby may need will be there and will be ready 24/7, any day of the week, any holiday at night, days, it doesn't matter. We always have access to the care for the most critically ill children, whatever that care may be.
And I mean, what do you have there? Can you walk us through some of the care and the technology that really only a level 4 NICU can provide?
Absolutely. So we have very specialized equipment suited to babies that are born extremely premature, all the way to babies who are at term. You know, in some cases, when babies are very ill after birth and they require help that's so significant with their breathing or their heart function, we can actually provide that type of care. That's something we call ECMO. And it means extracorporeal membrane oxygenation therapy. It's a way to provide heart-lung bypass. And that's really the most complex, the most intensive type of therapy that can be provided. We do that in level 4. So that's probably the most kind of sophisticated, most complex care you might need. That's not everywhere. Really, it has to be in a center like a level 4 center.
We heard from Mom and Dad there that they just felt loved and supported and cared for.
Important.
And Dad was a little emotional, you know, it was emotional for me too to watch him, but because you support not only baby, you really support the whole family. How do you do that during such an emotional time?
Well, it is a very good point that the patient is absolutely the focus, but the family is part of the team. And we have to always make them feel that way because it's so critical. Their presence, their encouragement, their questions, it's just absolutely so important. And we have to make them feel that. I think our nurses do that. I think our whole team does that. I think we're always keeping that in the back of our mind. And we have many services to support the family in our center, but we really just always have to keep that at the forefront of our mind, that they are part of the team. And I think that's how families get through such difficult periods.
You must build such strong relationships.
We do.
With people.
We absolutely do.
For you, what is so rewarding about this? Because you deal with hard stuff, scary stuff. For you, why do you do this in the NICU?
Thank you for the question. I really think that being a physician, specifically in this field, it's not a job. It's a calling, it's a vocation, and it's a privilege. So even on those most difficult days, you just are grateful to be able to be a part of a family's worst time that you hope, and you really work the hardest to make into something very good in the end.
It must be so emotional for you.
It is.
Because you see the sadness, you experience the joy. It's just all over the place. So yeah, you're right. It is a vocation, and definitely you're doing what you're supposed to be doing.
Thank
I can
you.
tell. I can see your heart. Thank you so much for being on the show today.
Absolutely. Thank
For
you.
more information, or if you would like to make an appointment with Penn State Health NICU, visit pennstatehealth.org/growing-your-family. As part of the special Good Day PA, ABC 27, Penn State Health Children's Hospital are hosting a web chat. To ask a question, go to abc27.com/NICU. Donna Kirker-Morgan joins us with viewer questions. Hi, Donna.
Thanks, Amy. Dr. Tim Palmer, neonatologist at Penn State Health Children's Hospital, is here with us to answer some of your viewer questions from our web chat. Thanks for joining us. We're going to start off with our first viewer question. Do you have a NICU at Penn State Health Lancaster Medical Center?
Currently, we do not. We are in the process of building a level 2 nursery, intensive care nursery, that should open up in 2026.
Oh, that is exciting news. We have another viewer question for you. How do doctors decide when a baby is ready to go home from the NICU? This is probably every parent's dream to have that happen.
In general, a baby needs to be over 2,000 grams, which is about 4.5 pounds. We would prefer them to be eating completely all of the food they need to gain weight and grow normally. Sometimes they need home oxygen, but we like to have them off of the home oxygen or off of oxygen. And we like to make sure that they can maintain their own temperature and not need to be in one of those isolates that you may have seen on TV.
Oh, it must be a fantastic day to see a baby go home. Oh my goodness. Well, thank you, Dr. Palmer. We'll check in with you a little later to answer more of your questions. Stay with us. We'll be right back.
Welcome back. In the United States, between 10 to 15% of all babies born require care in a neonatal intensive care unit. That was the case for a central Pennsylvania family. Deborah Pinkerton spoke with Scott Douglas about their story.
Scott, thanks so much for talking with us. Can you take us back to the moment when you first realized that Lucy would need surgery? She would need to go to the NICU. What were those early days like for you and your family?
We kind of found out right after she was born that she was struggling to breathe pretty significantly. The nurses were, trying to do what they could to get her oxygen levels up. She came out a little blue, and it all went very quickly. Ultimately, they called in the NICU nurses, whisked her right up to the floor above the NICU, and it took us by total surprise. We had no idea kind of leading up that anything was wrong. And it was quite a mix of emotions, right? You start with, elation from having a brand new little one. This was our first kiddo, to then the shock and worry of having a kid that wasn't healthy and might have some major issues. And so that was obviously very, very stressful and a really significant mix of emotions.
Yeah, as a parent, I can't imagine going through something like that. So the doctors told you that she would need surgery because her jaw was too small. So what did this diagnosis mean?
So we kind of knew shortly after going up to the NICU that they had figured out what was wrong. So she had a very small jaw, as well as a cleft palate, something they call Pierrot band sequence. Finding out that she needed surgery was obviously very, very scary, but also a little relieving because we knew that we had to fix the problem and we knew that there was an option to do so.
How was it watching your daughter go into surgery? And how did the whole team there at Penn State Health Children's Hospital really wrap their arms around you and let you know that it's going to be okay?
It was actually interesting. I did my medical school at Penn State, and I did rotations with our surgeon, Dr. Henry. And I knew the anesthesiologist. He was a class below me in medical school. And so I felt very comforted because I knew they did a wonderful job. I knew they were in good hands, but obviously it's still very scary, right? And knowing the post-op recovery, which you would have to go through even, a week after the surgery, was obviously very scary, but I knew I was in good hands from the physicians we were working with, as well as the nursing staff was very comforting.
So how did the surgery go, and what was the outcome like?
So she had something called a mandibular distraction. So basically they cut her jaw on both sides, put in some metal hardware, and then over the course of a week, expanded her jaw bit by bit. And so through that entire time, she had a breathing tube down. because of the risk of breathing with doing those expansions. And so that was definitely the hardest time that my wife and I had to go through, is watching her with a breathing tube. And, one thing I will never, ever forget is watching a baby try to cry and nothing coming out, right? They can't make any sounds. And that was just the hardest, most gut-wrenching part of it. But eventually we got through it. She got the breathing tube taken out and she did great. She could breathe on her own. It was wonderful. But it was hard to go through for sure.
Now that you're on the other side of this journey, what advice or words of encouragement can you give to our viewers who may be going through something similar to this?
Don't do it alone. We were very fortunate that, we made some friends in the NICU. We called them our Bay Buddies. And it's really hard for somebody who hasn't done it before or isn't doing it to understand what you're going through as parents. And so when you make those connections with people who are doing it and going through it with you, that made all the difference.
Thank you, Scott, for being with us, and so glad that Lucy is doing so well.
We are too. Thank you.
Thanks so much to Deborah. For more information, or if you would like to make an appointment, call 717-910-1638 or visit pennstatehealth.org/growing-your-family. We'll be right back. The NICU team at Penn State Health Children's Hospital works very closely with the hospital's maternal fetal medicine team. Their goal is to make sure every mom and baby delivered gets the best care possible. Earlier, I spoke with Dr. Jamie Pauli, Chief of the Division of Maternal Fetal Medicine at Penn State Health.
Doctor, we so appreciate you being part of this special program. Let's talk about maternal fetal medicine. What exactly is that, and when would an expectant mother need to see a specialist like you?
So maternal fetal medicine is a subspecialty of obstetrics and gynecology. Our focus is on high-risk pregnancies, and those high-risk pregnancies may be because the mom or the patient has issues, or the baby has issues that might need further evaluation and treatment.
Can you elaborate a little on what sort of conditions or complications would make a pregnancy high risk?
So from the pregnant person's perspective, it may be that the patient has pre-existing medical conditions such as diabetes or high blood pressure that requires medication. We also take care of a lot of patients who may have heart conditions or lung issues that can affect both how the pregnancy is carried, but also delivery things. For the baby, it could be a baby that's born with a birth defect, such as a heart defect, or a baby with a medical or genetic condition that might require additional monitoring both during the pregnancy and then additional treatment in a higher level of care after the baby's born.
You have two patients here. You have the mother, you have the baby. So how are you able to monitor both of them to really ensure a positive outcome?
Sometimes we even have more than two. Sometimes we'll have 3 or 4. So a lot of the monitoring that occurs is done in maternal fetal medicine with ultrasound. We also monitor fetal heart rates. We monitor the patient's blood pressure. We monitor how the patient's pregnancy is progressing in terms of how well the baby is growing, how well the mother is tolerating the pregnancy. So basically, it comes down to more frequent visits, more ultrasounds, and more consultations with specialized providers that might be there for either the mom or the baby or both.
Sometimes when a baby's born, that baby needs immediate care. So I'm wondering how you coordinate with the NICU and pediatric surgery teams.
So we are very lucky to have the Complex Fetal Care Center at Penn State Health, which is a multidisciplinary program that brings together obstetricians, maternal fetal medicine doctors, NICU doctors, pediatricians, pediatric surgeons. And that group gets together regularly to review the cases of patients who may require higher levels of care or immediate intervention. Together, we create a delivery plan. We make sure that everyone who needs to be at that delivery is there, that we're doing it in the most controlled way. And it's really, honestly, it just comes down to communication, constant circling back, making sure everybody's on that same page and we're ready for whatever kind of shows up.
That's exactly what I was thinking. Constant communication and constant care. So you guys are a well-oiled machine. You have it covered. Thank you so much.
Thank you for having me.
Thank you to Dr. Paulai. For more information, or if you would like to make an appointment with Penn State Health Maternal Fetal Medicine, call 717-531-7373. We'll be right back. The NICU team at Penn State Health Children's Hospital works very closely with the hospital's maternal fetal medicine team. Their goal is to make sure every mom and baby delivered gets the best care possible. Earlier, I spoke with Dr. Jamie Paulai, Chief of the Division of Maternal Fetal Medicine at Penn State Health.
Doctor, we so appreciate you being part of this special program. Let's talk about maternal fetal medicine. What exactly is that? And when would an expectant mother need to see a specialist like you?
So maternal fetal medicine is a subspecialty of obstetrics and gynecology. Our focus is on high-risk pregnancies, and those high-risk pregnancies may be because the mom or the patient has issues or the baby has issues that might need further evaluation and treatment.
Can you elaborate a little on what sort of conditions or complications would make a pregnancy high risk?
So from the pregnant person's perspective, it may be that the patient has pre-existing medical conditions such as diabetes or high blood pressure that requires medication. We also take care of a lot of patients who may have heart conditions or lung issues that can affect both how the pregnancy is carried, but also delivery things. For the baby, it could be a baby that's born with a birth defect, such as a heart defect, or a baby with a medical or genetic condition that might require additional monitoring both during the pregnancy and then additional treatment in a higher level of care after the baby's born.
You have two patients here. You have the mother, you have the baby. So how are you able to monitor both of them to really ensure a positive outcome?
Sometimes we even have more than two. Sometimes we'll have 3 or 4. So a lot of the monitoring that occurs is done in maternal fetal medicine with ultrasound. We also monitor fetal heart rates. We monitor the patient's blood pressure. We monitor how the patient's pregnancy is progressing in terms of how well the baby is growing, how well the mother is tolerating the pregnancy. So basically, it comes down to more frequent visits, more ultrasounds, and more consultations with specialized providers that might be there for either the mom or the baby or both.
Sometimes when a baby's born, that baby needs immediate care. So I'm wondering how you coordinate with the NICU and pediatric surgery teams.
So we are very lucky to have the Complex Fetal Care Center at Penn State Health, which is a multidisciplinary program that brings together obstetricians, maternal fetal medicine doctors, NICU doctors, pediatricians, pediatric surgeons. And that group gets together regularly to review the cases of patients who may require higher levels of care or immediate intervention. Together, we create a delivery plan. We make sure that everyone who needs to be at that delivery is there, that we're doing it in the most controlled way. And it's really, honestly, it just comes down to communication, constant circling back, making sure everybody's on that same page and we're ready for whatever kind of shows up.
That's exactly what I was thinking. Constant communication and constant care. So you guys are a well-oiled machine. You have it covered. Thank you so much.
Thank you for having me.
Thank you to Dr. Paulai. For more information, or if you would like to make an appointment with Penn State Health Maternal Fetal Medicine, call 717-531-7373. We'll be right back. Welcome back. As part of the special Good Day PA, ABC 27 and Penn State Health Children's Hospital are hosting a live web chat. Donna joins us again with more.
Thanks, Amy. Dr. Tim Palmer, neonatologist at Penn State Health Children's Hospital, is back with us to answer more viewer questions. Thanks for joining us. Our first viewer question is, what support is available for parents while their baby is in the NICU?
Okay, well, as a freestanding children's hospital, the support of the ill children that are inpatient A lot of it is done by the Child Life Program. Within our unit separately, there's physical areas for the parents through the Ronald McDonald room. There's ability for parents to sleep in the rooms with their babies. There is the Ronald McDonald House for babies that have been, families of babies that have been transported from long distances. I think in the past decade or two, NICU has become particularly focused on incorporating the parents into the care of their baby.
And surrounded.
Everything from being with us on rounds so they can hear and ask questions, and being available 24/7 for their care.
That sounds fantastic in such a stressful situation. Our next viewer question is, how do NICU teams care for babies who need surgery right after birth?
Well, we generally will stabilize the baby. As with what you saw there, we probably are doing the initial intubation and the initial diagnosis along with the surgeons. Once the surgeons do their surgery, we generally take over the primary care of nutrition, pain meds, those sorts of things, and work in conjunction with the surgeons.
Well, thank you so much, Dr. Palmer. You will be here until answer questions until 11, so stay with us. He'll be here, and we will be right back.
Welcome back. We thank the team at Penn State Health Children's Hospital for today's special program, and of course Waylon's family and Scott for sharing their stories with us. Our NICU web chat will run until 11 this morning, so you do still have time to get your questions answered. For more information, or if you would like to make an appointment with Penn State Health Children's Hospital, visit pennstatehealth.org/growing-your-family.